So, welcome, and I know that as we're heading towards the end of the program, I mean, all of these great workshops and great presentations kind of get pushed in close together. So I wanted to thank you all for being here, and particularly I want to thank a few members of this core team who've really been incredibly helpful at putting these ideas together. And so, of course, Raquel, thank you so much from APSA. This is you are all, those of you who are here, are part of a group that is going to help develop a shared APSA CAPS pediatric surgical safety checklist, which I think is really a great product from our two organizations. We'll also be working with the anesthesia groups as well for pediatrics, as well as the OR nursing staff, and working with parents and families too. So it's a huge opportunity. I want to also specifically thank Raquel, Mercedes, Pramod, Sean Rangel, who's not here, Robin and Caitlin, and many other members of the team. There's lots of smart people in this room who I have tremendous respect for and who I'm really excited to hear ideas from. So that is what we're doing. We'll go through a very quick introduction, and we're going to try and use most of our time for these small and large group discussions. So I am really enthusiastic to hear about your ideas on how we can develop this surgical safety checklist and think about how we can use them as organizations. So I'm going to hand this over to you.
So we're all here because we know the importance of surgical quality, right? It ensures that our patients experience the best outcomes possible, reducing morbidity and mortality. It's optimizing resource utilization. It's improving efficiency by streamlining processes. It's promoting health equity by reducing disparities. And just turn it off. So what is high quality pediatric surgical care, right? It's a safe, effective, timely, patient-centered, efficient, and equitable approach to the surgical interventions for all of our children. We have an APSA Quality and Safety Committee, which seeks to develop, support, and promote initiatives and programs that serve to improve the quality of pediatric surgical care. And we've had tons of literature from the Canadian side and the US side saying that we need to improve the quality of our children, that we need to work in collaboratives, that we should come together. So as we look at ourselves as APSA and CAPS, why not come together across borders and work on improving the efficiency of the care we provide? And that's what this workshop is about with the lens of the surgical safety checklist.
So a quick introduction to the surgical safety checklist and some of the work that we're hoping to do through this collaborative. In terms of disclosures, the key disclosure I would have for this event is that I am the director of Safe Surgery and Safe Systems at Ariadne Labs, Harvard's T.H. Chan School of Public Health, and we regard ourselves as stewards of the surgical safety checklist through research and development. So, of course, there is a long story behind the surgical safety checklist, and that did not begin with a checklist. It began with a problem, and that problem is the unacceptably high rates of morbidity and mortality associated with surgery. So the World Health Organization tapped Atul Gawande and his team to try and develop a tool that would help mitigate the risks associated with surgery. And rather than focus on individual things such as perioperative antibiotics, blood transfusions, instead this team tried to come together and look at communication across surgery itself and looked at 3 time points in surgery where critical conversations needed to occur and critical processes needed to be performed. The surgical safety checklist was the result of this. And this, of course, has been widely spread and scaled. It's across more than 4,000 hospitals worldwide. Roughly 2.5 billion patients have benefited. And when we actually look at the results of implementation of the surgical safety checklist, it is incredibly effective. So when we actually think about it in our current practices, we can sometimes get a little grumbly about it. But if you actually look at what the implications are of the surgical safety checklist in well-performed studies, we see that overall there's a pooled 20% drop in perioperative mortality. Now, when the checklist was first being rolled out, there were a number of pediatric groups that got really interested and excited to try and figure out what this should look like. Eric Skarsgård led a group of the pediatric chiefs from Canada to look at some of the recommendations around what the pediatric surgical safety checklist should think about. And implementation was a key part of this, how to make this work for our populations of children. Some of the other recommendations were including a beginning of the day huddle, encouraging meaningful participation of all members of the perioperative group, looking at the use of the checklist for outside procedures outside of the OR, and also the importance of audit in the process. We have since looked at the literature that's been published on the surgical safety checklist in kids, and we found a number of different things. Now, there's not a lot of studies that are out there, but some of the key findings were that parental involvement leads to improved satisfaction and perceptions of safety. That is both for families as well as for the surgical team members, and that intensive implementation, which is particularly tailored to the pediatric population, through the use of feedback, education, and stakeholder involvement, does improve outcome across a number of different spheres, including critically important clinical outcomes. We know that there are opportunities to take existing checklists and renew them, and we've seen great results from doing this in places like Singapore, where we've worked with teams that are already extremely high performing, and then actually focused, rather than just at trying to achieve competence, to achieve true excellence in surgical teams, and have seen big changes in surgical culture as well as safety events. And we've reflected on that in some of our publications. So at the time we put these slides together, we had over 85 respondents. We've now got around 95 respondents, approaching 100. And what we've seen across the APSA and CAPS community is that there's overwhelming support for maintaining core safety checks, but there's also opportunities for us to make the checklist better. Smarter, more interactive checklists, potentially with EMR integration, clinical decision support, pediatric-specific adaptations, weight, development needs, centering the patient and the family in the checklist, and looking at how we can address some of the complex surgical risks in our patient population and acknowledge that many of the cases that we take to surgery require a bit of a different approach to perioperative conversations. There's also real desire to streamline this and look at what's redundant. So overall, I believe that restructuring and rethinking about the surgical safety checklist does provide us this opportunity to look at the future of pediatric surgery and quality and safety, and to address some contemporary priorities. We can ensure not only competence and safety, but I feel like as our two different organizations can go beyond this to really look at excellence in specialty-specific complex care, and we can capitalize and recognize evolving technology. So what we're going to do, if anyone has come into the room after we handed out some letters, do not worry. Anyone who was in the room at the beginning is going to have a letter, A, B, C, and D. Please go to the tables that are here according to your letter. And if you don't have a letter, don't worry. Just go to a table that's got fewer people at it. So please come up to your groups. We have key leaders for each of these groups, and can Robin, where's Marion going to be, and where can you help Raquel and Marion to the? Okay, so within these groups, there are three things that we would love for you to. Yeah, within each of these groups, there's three elements that we want to talk about. Don't worry so much about this first element, which is the critical components of the existing SSC. You can talk about those and spend a little time if you like on that, but really what we want people to spend their time in are discussions around elements that may not be in there that we should think about, or some critical elements of that. And then for the second part of this, to really focus on things that we can think of in terms of form and function and implementation. Each group has a chair who's going to take down ideas. Please feel free to lead the conversation, gather ideas as you will. We will have a little timer for you and help you move through this session, and then each group is going to present back at large. Don't worry, be creative, be bold. We're not going to leave this with a final product, but we really want to leave with ideas and reflections. Okay, everyone. I wonder if you could take the next minute to wrap up the conversations. I know we probably barely scratched the surface, but we'd love to be able to start presenting back to the rest of the group. I can say I'm really excited about how much conversation there is in these teams. So as we're preparing for each of the groups to present back to the full group, first off, I'll say, and I think I said this at the beginning, that this is the beginning of the process. We have a group of people who are really interested in continuing this core work with us. And if other folks are interested as well in being engaged, please reach out as we go. We have similar work that we're going to be doing with our pediatric anesthesia colleagues, as well as our OR nurses. I'm also really happy to see a number of trainees in the room because we didn't have a ton of trainee responses, so it's great to have that engagement also. Really excited about that. We're going to have each group present, and there were going to be things that not everyone had an opportunity to put some of their ideas out there. So please feel free as each group gets up, if you are in that group and there's some things that you've been reflecting on the discussion and you want to add, please add those in. Everyone's going to be happy to hear them. And if someone in a group says something that you're going to say in your group, you can feel free to either just say, and we agree with those comments, or you can add, whether your group had a slightly different perspective on that. After the groups have presented, I really welcome everyone to sort of add their additional thoughts and comments. And when we close out, we're going to be sending you all a bit of a summary of what we've learned from the surveys with the rest of our results that we've got back, and a bit of a next steps discussion. So we'll start with A, and I think that's you, Pramod. Is that your team?
Thanks. We had really good discussion. And I'll just invite my group if I forget something or didn't say it correctly.
Do you want to come up here? Do you think it's...
Or I can bring this over.
Oh, yeah, bring
Yeah.
that over. That's great, thank you. Yeah, we'll bring that over.
And so there's some people that are hiding behind the pillar. Should I move over here? Sure. I don't want to. It's good this way. All right.
Yeah, I can hold it.
Oh, yeah. That's good. We had a really good discussion. Fortunate to have a trainee with us as well, and other perspectives, a consumer of the healthcare system with us as well. So that was actually pretty important. We were talking about things that could occur before, and we interested to hear what other groups was sort of the compliance aspect of that 735 huddle, and what are the elements, and whether you're doing the 735 huddle, should there be another huddle if the team changes at 11 o'clock for lunch, or at 2:15 or 2:30 when there's a shift change. There was this comment about how to navigate the parental presence at induction with the processes of the surgical safety checklist, and how we might be able to do that, and perhaps make it not sound like we don't know the patient at all and we're repeating everything, and the families are kind of thinking to one another they really don't know what they're doing. Other really interesting things that came up were updating the H&P. There seemed to be variability. Was it same day verification of the H&P on the day of the surgery, or was it within a 30-day window, or was it within a 3-month window? There were other things that, about, confirming room temperature, the type of prep, particularly for neonates, and the fact they're using 0.5 or 2%, and or whether or not the skin prep was actually even done. which should be done at the timeout, which there were some anecdotes of patients having surgery and they just draped the patient assuming that it was a clear prep. Other things that came out were also respect to sign out, which was wound class verification. So was this a class like a dirty wound, like a clean contaminated wound, which would be very helpful. During the procedure or during different components of a multi-stage procedure, would you check airway? So if you're going from abdominal to perineal, or if you're going from the chest to the belly, should there be a way for the team to sort of reevaluate that? We talked about medication reconciliation and where that occurs, and for most people it did not occur at the time of the safety checklist, but it happened somewhere in the process. And then one of the other elements that came up was, does everyone have a resuscitation sheet that would have the current weight and all of the resus meds with the dosages that would be readily available, even in the context of an EHR? It's probably in the EHR, but would you have a piece of paper that someone would be able to, readily access without having to run to the computer in order to get that information? I don't know if there's anything else that I missed. With respect to implementation, we kind of got into some aspects. One was, and Dr. Skarsgård brought this up, was sort of a very detailed compliance checklist, like a 3x3 box, so that all parties have checked it off. It's not just a binary, yes, did you do it, did you not do it? And then whether or not the implementation of this should be occurring outside of the OR setting. So procedures that are being done in NICU, ECMO cannulations in the PICU. If you're in a hybrid suite and you're off in radiology, perhaps with an OR team, should the same process, or is the process being respected over there? So I don't know if there's anything else.
Thank you. Thank you so much. We are taking these notes. Yes, I'm happy to hold. Again.
So for items that are missing, I think we talked about a lot of the same items, so I won't necessarily repeat all of those. With regards to the resuscitation sheets, we also talked about that, including what the patient's blood volume was, super relevant in pediatric patients. We talked a lot about the fact that introductions, while they are on the checklist, we want to find a way to make them actually meaningful introductions so that everyone truly does feel that this is a safe place and they are a part of the team and they can speak up. And so how to create that as a more meaningful piece of it rather than just like a checkbox that, yes, we all said our names. Particularly in looking at the WHO original checklist, we were talking about avoiding some subjectivity. So in some cases it says like site marking if applicable. What is if applicable? Should I be marking the belly button if I'm doing a laparoscopic procedure? Should I not? And just making it really clear what the expectations are so that everyone would read it and interpret it the same way. We talked about sort of knowing the patient well coming in, what resuscitation has happened already, and what are the goals of that resuscitation in terms of it might be fluid or blood, just so that everyone really is on the same page, recognizing that it's a new anesthesia team that's taking over maybe a resuscitation that's been started in the emergency department. Contingency plans we see as sort of in the timeout, and we pictured moving some of that to the earlier stage, the briefing stage, which relates to one of our lower points that in looking at the original WHO, the surgeon is not necessarily present for that first stage. And we think maybe some of the pieces in the brief could actually be moved, in the timeout could actually be moved to the brief with the expectation that the surgeon is present at all three. We also talked about even adding a pre-column for that early morning huddle checklist so that we could add all of the missing elements there. A few smaller things like making sure end tidal CO2, not just pulse oximetry, is measured, talking about critical equipment, and then really thinking about the patient as a whole and what might be relevant to their case beyond just allergies. So if they have IBD, that might be important to know up front so they don't get NSAIDs if that's part of your practice. Knowing if they have, a single kidney Vactral, again, those sort of patient-related factors that may impact anesthesia care. So those were sort of our missing elements. Did I miss anything, team? Okay. In In terms of implementation, we had a great group, including some people who have seen this used not a lot, which I think is fantastic. So we could sort of think of this as if this is the information we want to use, how would we ideally like to do this? We chatted about how a lot of us have posters in the room. One really good idea I heard is that some hospitals change those every few years intentionally, even just like color change, logo change, so that it isn't just like has become a part of the wallpaper. So we talked about actually modifying it to keep your attention, which makes me think we should do that at home. Also having sort of color coding so it's clear who is responsible for each piece. We talked about a lot of sort of role clarity that often lacks in terms of, do I start it? Does the nurse start it? Does the anesthetist start it? And making that really, really clear from the outset so that everyone can use the piece that they're responsible for. We talked a lot about how this really takes a surgical culture to do well, and that in some places it requires enforcement to force that surgical culture, using things like repercussions if you don't use it, also empowering the nurses to not physically hand you the blade until it has been done, but hopefully creating a culture where this is something people want to participate in because they see safety and not necessarily just doing it for those consequences. Random audits have worked well for some people so that you sort of always have that feel that you might be being watched and maybe you will do better. In this case, we're willing to take advantage of the Hawthorne effect. We think that's fine. If it makes you do a good job, no problem. We have the black box, so I feel that constantly when I'm like, ooh, they skipped their line. I'll say their line and we'll still get full credit for it. We talked about it being a really active process, and rather than just sort of me running down my list, someone providing a closed loop, like I actually heard that and processed that and accept that, rather than it being more of a checkbox. We talked about ways of trying to make it be quiet or calm, ringing like a bell to indicate like almost a Pavlovian response, like you hear that and then everyone in the room shuts up and you're like, okay, this is the surgical safety checklist, instead of someone in the room trying to be like, everyone stop talking, and just finding a way to consistently be like, this is the time, whatever that may be. And then really coming back to that culture, talked about really owning your role within it rather than seeing it as an audit, and how to sort of make that happen as players who use the checklist. Anything else I missed, team?
Oh, these are fantastic. They're so good. Okay, we're going to keep it. Okay, our next group. Hold this in here. No worries.
I want to thank our my group, but especially because we had medical students, and so that was good to get their perspective. And as they're trying to learn the surgical world, they were able to contribute, and I'm very thankful for that. In terms of elements that were not there that we thought were needed, special equipment, right? So do we need something particular that we want to make sure it's there before we start the case and that it's actually functioning and working well, or in terms of modes and settings for laparoscopy and things that are unique to that particular procedure that we would like that to be called out beforehand. Do we need blood products, right? So am I doing a liver case or a liver transplant and I want to know that I have the blood, that the blood consent is there, is a patient typed and crossed? Those are things that are very important for us to know beforehand. Is the patient dependent on chronic medication? So is the patient on steroids? Does the patient need stress dose steroids, right? So all of those are conversations that are important to know and be part of the checklist. Is a pregnancy test done? So a lot of times, at least at my institution, it has to be done for any female 10 and older. And that's sex, right? So female sex at birth, right? And that can cause confusion. So knowing that status and knowing that policy. The fire risk, right? So we do a fire risk and we give it a 1, 2, 3. So that's important to know. Am I doing a high fire risk operation? And so we thought that was important to include as well. Special circumstances. So is the patient a Jehovah's Witness and cannot get blood, or, right? What are those situations that we need to know beforehand? The chlorhexidine wait time. So sometimes you have to wait, but it's a little loose at times. So some people wait 3 minutes and some people don't. And some people remind you that you can't start for 3 minutes. And so that was important as well. The roles. So Mercedes talked about that, but also knowing the name, who you are, but actually what's your role. So if there's a complication, I know who to look for to get me what I need at the moment that I need you. The other thing we talked about was in terms of implementation recommendations. So OR monitors to include the actual elements, right? So, but for those we looked at it a little bit beyond the US and Canada. Perhaps monitors are not available at other places, but at least a visual cue, not just a checklist that people cannot see. So displaying it so people can actually see the elements and be involved. Training for the OR members, right? So that everyone knows that this is important and what are the elements. Institutional support so that people feel empowered, so that when I'm ignoring the timeout or when I'm trying to rush, that somebody calls me out and says, hold up, let's actually be intentional about this. And then tracking, right? So nothing like having a checklist, but then you don't track if people are using it or not. So that's all we had. Oh, that's wonderful. Thank you.
I'll make you all pivot this way. So much of what we discussed was already, has been covered by the other three groups. So I'll try to jump to the items that I haven't heard yet. But one important one was discussing whether a block had been done and how much local were you able to use, and if there are other teams who might also need to be using it. So if you're doing a combined case, did they already use the allotted amount so you don't actually get any or block? I loved this idea because this is not one I've ever heard before, but one institution has something called Voices, which is how often are you going to touch base during the case? How often are you going to kind of repeat a briefing process to talk about how much blood loss has there been? Should we be giving product? Have we started pressors, but you don't know as the surgeon? Or, what is it a critical part of the case coming up? So it's a really bad time for your nurses to suddenly shift out, or your anesthesiologist to shift out, or just everyone to be aware there's a critical case coming up. I might need quiet in the room. Critical parts of the case, I like music off. Derek likes music, but being aware of what that situation might be. We felt that there were a few things on the checklist as is that are happening at the time of right before incision, when the patient's already asleep and prepped, that maybe should be happening at an earlier piece, like making sure that the equipment needs are already verified, because if you don't have that critical piece of equipment, probably shouldn't be already asleep and ready for surgery to happen. As well, it talks about estimated blood loss and having IVs, but do you actually have the blood products you need available if you should need them a priori, or if you think you might be needing them. We didn't see DVT prophylaxis or anticoagulation needs mentioned on that, so that was another thing in the briefing. And then the debrief, the wound class, lessons learned during the case, what went well, what didn't, what have we learned from it, needs in PACU and post-op, and also do you have an X-ray policy for potential return for an object, and did you leave things in that need to be documented? Do you need to, by policy or not, get an X-ray? In the briefing area, we thought, especially in places where you're maybe in a hospital that mostly does adults, but you're a pediatric unit in the hospital, or if your whole health system is putting together a uniform checklist, a separate part that also includes critical aspects for pediatrics, like is the patient's weight documented, and you're going weight-based? Do you know you're on the proper Bovie settings, on the proper laparoscopy settings for a pediatric patient? And then for implementation, really knowing when are you doing your briefing? Is this, and who's supposed to be involved? This checklist, the surgeon's not involved, so the nurse might not know the equipment you need. There are critical aspects that are in that early part that the surgeon maybe should be involved in. And really making that pretty prescriptive as to when's it going to happen, who's involved. And then really getting the culture of everyone's attentive and involved in this process especially the timeout in the room, so that it creates that culture of safety and everybody has a voice to participate, but also everyone is aware and knows, isn't missing elements of that. Team, did I miss anything?
Which might mean waiting. If
Which-
anesthesiologist is busy.
Yes. It's,
Seeing-
everyone has to be ready.
seeing if they're actually ready.
Thank you so much. This is excellent. I have, we are closing up, but I have a question for this group. In pediatric surgery, we are often dealing with a very large group of very simple, straightforward patients. And then we have a small group of incredibly complex patients that need a lot of discussion and a lot of planning. And I'm just interested in whether people either in their teams or even just have ideas about how a checklist might address that huge scope of the kinds of patients that we see and ways to think about it.
Yeah, I'm sort of curious about that because there is, sort of a hidden curriculum around, okay, I have a day of, 5 or 6 hernias and, I want to get through this and I don't want to be people rolling their eyes at me when I'm insisting on, meeting all the elements. So I have not seen the idea of, okay, this is sort of your low-risk checklist or high-risk checklist, but, there's a lot of elements for those simple outpatient surgeries, local hernia repair, foot hernia repair that, don't apply.
Well, think ear tubes, right?
Yeah.
So like the ENTs hate this. At least in our system, they're just like, you've got to be kidding me. This takes longer than the ear tube, right? So the valves, right?
I think it's a really relevant thing, and it's interesting, we at our hospital, we have a separate checklist for complex neonatal cases, and people love it. It's like the opposite, because they know that there's so much more discussion about some of those critical elements that are going to happen. So I was interested to sort of get perspective of what people have seen work and not work.
I like that idea of a low risk versus high risk, and I also think it then goes, whoa, this kid was on my ear tube day, but shouldn't be, right?
Mhm.
Like, it's the comparing like that, it's simple ear tubes, but maybe it's, I don't do ear tubes, so I don't know, but every now and then you have that patient who the scheduler puts on your 20, whatever, your 6 hernia a day or 8 hernia a day, and you're like, oh, no, that kid should not be on the low risk day, right? So it also makes you think, wait, that's not a low risk kid. We should move that.
And it's also great, for the huddle, to be able to recognize some of those cases at that time too. I think it's this great opportunity. First, okay, go ahead. Yeah.
As far as classifying low risk or high risk, I think another criteria that can go into that is even just the alternative time that you anticipate. That it's like it's a 10-minute case or 15-minute case that you can use that as an objective thing to say this is low risk.
Yeah. I think there's probably some metrics that we could use that could help us with that.
I think the whole thing, across the big system, a lot of times it is those ear tubes to the wrong side. Or
Yeah, there's still a real need for it.
Yeah, it's that's where you have a big burn. One thing that we've had a lot of root cause analysis things is you do all the checklists, you do the posters, but what about forget things? Every time you catch a specimen internally, it gets written on the board until it comes out of the patient and then gets crossed off and erased. I'm doing cryoablation. They got a good resident. I watch you start. I might leave the room, give some independence, but who is counting? So they write the numbers on the board, cross them off, then erase. There's things that we just say on the whiteboard, dirt sheet.
Yeah.
And
Yeah, and I do feel like when the checklist first came out, people were very afraid to make it flexible. And there were lots of great reasons for that, but I feel like we're probably at a stage where flexibility is possible. I recognize we are at the end. I'm really excited that we stayed on time-ish. If anyone has any other thoughts or ideas or anything they want to share, please reach out. This was a really exciting session, and I really appreciate all your ideas. Thank you.
Mary, thank you for bringing your team.